and welcome to Freedom Hub's Health Biz and Politics, where we feature innovators and disruptors, policymakers, et cetera, who are working to deliver more effective and affordable patient-centered healthcare, something the conventional cartel-driven system, which is more concerned with profits than healing, has lost sight of. I'm Jim Grapek. I am joined by my co-host, Charles Frohman. We have an interesting show for you today. But let me start with a little housekeeping. If you're new to the channel, our website is your-mp.com, your marketplace for health, wealth, and freedom. Lots of good stuff here. If you have the time, look through it. But in terms of our webinars, go to your media hub, click on that, and you will see who we have coming up that week. Health Biz and Politics show, also our Thursday Freedom Hub show. These have been ongoing continually now for 5 years. We've had great speakers. Down at the bottom here, you'll see where we post our shows: BitChute, Brighteon, Rumble, and YouTube if it's not too controversial. And with that, let me stop the screen share and turn it over to you, Charlie, to introduce our topic and our guest.
Gladly, Jim. Thank you, and welcome, Josh. Josh has a good background for today's topic, Health Reformers Academy, because I think a lot of center-right activists shy away from the Obamacare issues because they don't understand it. Insurance is complicated. I know that as a licensed insurance salesman, families and business owners don't really know what they want, or what they say they want is pretty trivial. What's my copay compared to what are some of the bigger issues? How do we heal our workers, make them healthier, and save money and give them choice all at the same time? Prior to founding Health Reformers Academy, Josh founded President's Lane Consulting. And for those of us in the know, he was a fellow in health policy at the Heritage Foundation, which when I was a congressional staffer in the 90s fighting Hillary Care, they had a scholar named Stuart Butler who really educated us on how to individualize the market, because it's basically a group model where benefits depend on where you work. One size fits all for all the employees. Even more equally interesting, he has a background in the Massachusetts government, in the state Senate and the governor's office. And for those who kind of know Obamacare, they know it came from Mitt Romney, Romneycare. And I guess there was some good thinking originally behind it from the heritage individualization approach, but like every other government solution, it was taken over by the special interests and made top heavy, and folks actually don't know how to fix it in most cases. Maybe Josh has some good ideas. With that, Josh, take it away. Tell us about Health Reformers Academy, and then we'll have a good Q&A afterwards.
Great. Well, thank you so much all for having me. Really appreciate the opportunity. So my plan for today was to talk a little bit about this Health Reformers Academy organization that we've started, why we started it, what we're hoping to accomplish, and a few different ways that you all might be interested in being part of the effort. I did also want to talk a little bit about a price transparency reform that I've worked with one of my client organizations that actually is a version of it has become state law that might be of interest to you all, I suspect. But let's start with Health Reformers Academy. So as was mentioned, I've been in and out of government for a couple decades now, and grew increasingly frustrated with a number of different things. Those of you that have tried to interact with policymakers can probably feel that tension at times, both because the turnover is very high, the knowledge base or context is very low, and they often are projecting things on what they think should be happening, or have a government first intervention. If you're a hammer, everything looks like a nail. But one of the challenges there is that there simply is not a talent pipeline of folks that believe that markets can play a role, that incentives matter in health policy making, that think that through. So that's why we started Health Reformers Academy. It's set it up as a nonprofit. Both myself and my co-founder both worked for governors in 2 different states, and this was a lingering issue. I mean, if you're familiar with state spending, healthcare spending is now the #1 line item. It is exceeded public education spending at the state level in every single state, and it's only going up. So this is certainly at the state level an issue that needs to be addressed, but even at the federal level, for those of you that have been watching some of the debates about Medicare, healthcare spending on Medicare and Medicaid is driving a lot of the federal long-term spending issues that we have. I mean, what's playing out in DC, the subtext, if you dig deep enough, is really about healthcare spending. And are we going to be able to figure out a way to have a sustainable pathway forward to balance all of the needs that different people on the ideological spectrum are fighting for when it comes to how to spend money? So my background outside of government has been in the think tank nonprofit world, and I've worked in 35 states. I've worked in DC. I was part of the first group that went to the Trump administration to pitch them on price transparency rules, and we got a resounding no in those first couple meetings. We were persistent, as well as some other groups, and as you all know, eventually something popped out at the other end, which we're hoping, that we're optimistic will have some positive effects long term. But that perspective of working in 35 different states, working in different political environments, lend itself to learning a lot of best practices for how to effectively move reform. And I think, well, the media generally likes to paint a certain picture that unless you support single payer, there are no good solutions on the table. There's actually been quite a bit of action at the state level. Some of it very promising, some of it more tweaking around the edges, but for myself and a few others that have worked in this space, there's been lots of opportunities to push forward. So what we are trying to do with the Academy is we're trying to find, recruit, and train the next generation of center-right or market-oriented health policy leaders. And we do that in a number of different ways. We do some virtual programming or boot camps online, but then our kind of ultimate offering is a fellowship in which people apply, they get interviewed, they have to get accepted. And the average profile of an individual who's part of that fellowship is one of two things. One is they're either probably in their late 20s, early 30s. They're very interested in health policy, both at the state or federal level, or learning more. And we're really helping them understand the basics. How did the American healthcare system evolve into what it is? What is Medicare? What is Medicaid? Who's on the program? How much money is spent? What are the debates? What are the acronyms you need to know to be conversational about these topics? How does the health insurance market generally work? Who regulates what? What does the state regulate? What does the federal government regulate? Who determines the rules of the road for providers? All of these really basic facts that if you're going to be in a policymaking role, you would at least need to be familiar, because the special interests certainly know their space very well, and they're going to come and speak into your ear. But the other thing for us long term is we want reform-minded individuals to have a network themselves, so that when they get approached by special interests, they can say, okay, I've heard one side, and they can call others in our network to find out the alternative perspective, to learn whether what the special interest is telling them passes the smell test, or whether they really should be highly, highly skeptical. And that's probably part of our value, is just to make the future policymakers a little bit skeptical about the lines that they're often fed when they sit in those seats and everybody shows up and knocks on their door. The other profile is individuals who are interested in potentially becoming a political appointee or to run a state agency. So we have individuals, we have state legislators, we have providers who come through the fellowship who might know their niche, their lane of the healthcare world, but they know they don't know the full policy perspective, or they feel like they need some help understanding how to be an effective advocate, how to build a coalition, how you actually move reform. And so those are the other kind of profile that comes through. And so our goal is to spend time with them over a somewhere between 8 to 12 week period, learning these skill sets and then becoming part of this community. There are a couple different ways that folks like yourselves could be involved. One, if you know people who you think would benefit from this, have them go to HealthReformers.Academy, and they can find out all sorts of information about our effort. They can apply for the next cohort. They can email us if they have questions and set up a time. If you're interested in participating in the fellowship, we welcome anybody to do that as well. But the other piece of it is we're constantly looking for people in industry to speak to future policymakers or current policymakers that are in the fellowship. So if you feel like you're doing something a little bit different, a little innovative, we do continuing education for all of our fellows going forward. And we are always looking for people to come speak to them to say, here's what we're doing. Here's how it's working. Here's how the incentives are playing out. Here's the barriers that we've run into, whether they're a regulation that needs to be removed, or whether it's simply education. We need to make people a little bit more aware of that. That's an opportunity. The final way, I'll be remiss, since it's a nonprofit, if you feel called and want to financially support us, we'd welcome that partnership, of course, as well. So there's lots of different opportunities to interact with this. If you want to reach out to me and have a conversation about it just to learn more or to understand where we're pulling policymakers from all over the country, and we'd be happy to make introductions to people in the states that we're working with if you're in this space. That's a little bit about Health Reformers Academy. Let me transition for 1 second to talk a little bit about price transparency, because I think one of the goals of the Health Reformers Academy is to make sure that these future policymakers or folks that are currently working on the Hill or working for governor's office are familiar with what matters to have a market that functions. And so I want to talk through a policy proposal and then be happy to jump into Q&A after that we're calling Patients' Right to Save. And would love to hear your general thoughts on it. So let me share my screen here for 1 second. I'm just going to show you a couple slides here explaining the general reform. So Patients' Right to Save basically has 3 components. There's model legislation. It's been filed in a handful of states. I'm sure many of you are familiar with what has happened at the federal level, the tri-agency rule for transparency and coverage, and then the hospital price transparency rule. I'm sure you're also familiar with the headlines of spotty compliance for hospitals. And we sat back, some of us in the policy world, and said, what matters to get a market to work? What are some of the underlying issues that we have in the healthcare market? You all know it well: costs, lack of transparency, misaligned incentives. And we were thinking through, what is a lifeboat that we can put out there for individuals that will help them regardless of what is their coverage, whether it's traditional commercial insurance, whether it's a sharing plan, whether they're uninsured. What are ways that we can help all of those drive down the cost of care? And this is what we kind of came up with. The first is cash disclosure. So there are some gaps in the federal rules. And so this would say at the state level that any provider in the state would have to disclose what cash rate they would accept for a service. So the federal rules only require that for hospitals. And so we wanted to make sure that that sort of information was available to patients. We don't want to just know hospital A versus hospital B, what the cash price is, which we can go down this rabbit hole on why many of the cash prices being disclosed by hospitals are made up numbers and not very helpful at the moment. But this is to say, what is the cash rate that you would accept? Whether you want to go to an ASC or a hospital, that's really the comparison you want. All of your care options, not just one. So that's the first level. The second one is that if you go to one of these cash-based providers and it's below the lowest negotiated rate for your insurance company, let's assume we're talking about being on a commercial insurance plan here in the individual market, for instance, then you actually get deductible credit. You've saved money, so you should get deductible credit. And we believe that this aligns incentives for high-value providers to be rewarded with volume, and also allows patients that want to shop to not be penalized or discriminated against because their insurance company doesn't actually negotiate a good rate for them. And then the final one is related. It's just kind of fast forwarding through the experience. Let's say you're near the end of the year and you've gone through your deductible, whatever that might be. If you continue to use one of these lower cost cash priced options, then it actually triggers an incentive. And the insurance company actually has to pay the patient something. And you can use a third party. So I'm going to walk through a little example on this, that's pulled from a paper. We wrote a white paper on this, and we have, like I said, model legislation, but we gave a few examples in the paper. This is an oversimplification. So with that caveat, I know some on the call will probably say, well, that's not real typical for exactly how this works, but for oversimplification, for explaining it, here's a situation that we had. John's a 55-year-old man who was injured his knee playing basketball and needs an MRI. Somebody who's getting middle-aged, myself, I would know nothing about this world. But in this case, his insurance plan has a very generous, it has a $500 deductible, and he has co-insurance after that. You kind of see the situation explaining what his insurance plan looks like here. So under the status quo, we kind of have 2 scenarios. option A here is that there's an expensive MRI that he could go to that's in network. Let's say for the sake of this, it's $904. So how would that play itself out? Well, John would have to pay the entire first $500 because let's say it's January, he hasn't spent anything towards his deductible. So he would have to pay the $581 total with his co-insurance, and the insurer would end up paying $323. Well, if John found a $400 cash rate MRI out of network, he gets no credit. He's out of luck. And maybe people on this call would decide to go to the $400 option. Unfortunately, many Americans wouldn't. And they'd say, well, I'm paying for this insurance. I want some sort of credit. So I'm not going to do it. And they end up paying the $904 MRI just to get the credit. And so that's kind of our status quo. And so fast forwarding, if patient's right to save passes, you have a slightly different scenario here. For this, the paper kind of walks through what would happen under a few different scenarios, whether you were within your deductible. But let's fast forward to again, at the end of the year, and you've met your deductible. So what would happen here? If he continues to decide to go to that cost-effective $400 option, what the model legislation says is you don't have to use a third party, but let's say you do use a third party. Let's say they only get paid when you save money and they take 20% of the savings. Under this scenario, John's already met his deductible and he comes out way ahead. He actually ends up getting paid as a result of making this conscious decision. And there's a precedent for this a little bit outside of healthcare. I don't know if some of you are familiar. There's companies that auto renegotiate your cell phone bill or auto renegotiate your internet bill. And they only get paid once they've saved you money and they take a percentage. And that's kind of what we're envisioning here. And I think there are numerous cash pay platforms or providers that are out there that this would be very much aligned with their incentives going forward to be able to come out ahead. And the way that the reform is structured, and this gets at some of this nuance around understanding the policymaking process, is that in no situation is the health insurance company worse off than they would have been under the status quo. So when we're moving through this process, if the insurance lobby can come up with one scenario in which they end up having to pay more money, then they often are able to be successful in killing reform at the state level, because they've said, oh, look, this has driven up our administrative costs. This has driven up our healthcare spending. Why would you do that? Everybody knows healthcare spending is too high. The irony of health insurance companies arguing this. Under this reform, we have constructed it in such a way that we believe, and again, happy to hear people's skepticism or pushback if they have some. We believe not only does this create, for the first time, a real marketplace for those on and off insurance, traditional insurance. It's agnostic to what kind of coverage you have. The benefit, the cash disclosure helps them universally. But it also takes that argument completely off the table, and there's a scenario, because you have to go to a cash rate that's lower than the lowest negotiated rate for you to get the deductible credit. So we're optimistic about this. It did actually, a version of this passed in the state of Tennessee this past session. The speaker and governor and state senator, Kerry Roberts, got really interested and dug into it. The reform is a tad different. It's actually more generous than what the model bill is that we have, which says that if you go to a cash rate provider below the average in-network rate, ours was lowest negotiated rate, then they're able to get deductible credit. That's what their reform is that they passed. It was House Bill 1213. So if you're in this industry and you think you could benefit from this, there's a huge opportunity in the state of Tennessee that goes into law July 1st, 2023. And so that's one of the primary reasons I wanted to mention it, is there's a great opportunity here, and we expect a few other states to take this up later this year or in 2024. And for those that are reform-minded, market-oriented, we're trying to open a door here on the policy side, not be overly prescriptive, but at least open the door for a market to emerge and for you all to help send a lifeboat with your products. So with that, be happy to take some questions. We can talk. I'm happy to talk about behind the scenes policymaking. If you want some additional insight there, I'm happy to talk about the difference at state versus federal. whatever's interested, or if you have questions about Health Reformers Academy.
Charlie, what do you think?
Well, in chat, Charles had a question. If he wants to raise his hand, and he saw maybe a potential flaw in your transparency bill. Charles Ford, you want to clarify that chat comment?
Sure. Thank you. Very good presentation, and I think your organization is doing a great job, and I'm glad to become aware of them. And thank you for sharing that information. One of the things the carriers make a ton of money on is network utilization. They get a kickback on the use of the network. So when that price is $900, there's probably a couple hundred of it going right back into the pocket of the insurance company. I noticed that wasn't really considered in your model. You're cutting that out. The insurance company is not going to like that because it drives up the cost of their network and it keeps them away from a nice large pot of honey and gold from a revenue standpoint. So maybe you could take a moment and address that.
Yeah, so no doubt that the insurance companies don't love this. I mean, I'm sure many of you are familiar even with the medical loss ratio that was passed as part of Obamacare or the ACA, which mandates that for every dollar collected, a certain percentage of it has to be spent on medical care, which leads to prices going up. Surprise, surprise, as they get to keep more. Yeah, so certainly they don't like that. But the model actually doesn't care about that, because it puts the power in the patient's hands. So if they want to go to the $400 out of network cash MRI, insurance company can't do anything about it. As long as it is below the lowest negotiated rate, the insurance company will have to recognize it towards your deductible. That's what the policy, that's what the law says. That's what they'll have to follow. And no doubt, insurance companies don't. But here's the thing. Historically speaking, insurance companies have made two value arguments. They've said, we pool risk and we negotiate better deals for you. Turns out the second one's not true. You know, I think the federal price transparency law has done a good job of really exposing that. But for those of you that are in the cash market or familiar with that space, it is very clear that cash rates, while not always cheaper, are often cheaper, and often cheaper than the lowest negotiated rate for insurers. And so, as we've seen, and this is, my experience in Massachusetts, which in 2012, I worked on a price transparency law, which I would argue was probably the most robust at the time, which was any patient could get the negotiated rate between a health insurance company and a hospital for their plan. We saw the variation, which is now in our world, this is well-known thing for most Americans. I still don't think they fully comprehend it. The variation of rates by just driving a mile or two is just, mind-boggling, right? 10x, 100x in certain cases for the exact same services. So they're certainly not negotiating the best rates. But when you start to look at the cash rate market, you start to realize, okay, well, there's a few pieces that are peeling this apart. One is they don't have to deal with the insurance companies, have the administrative burden. They don't also have what you highlighted, which is a number of other things that inflate the rates. So the thought here is that once you have some percentage of the market, 20, 30% of people taking advantage of this door that we're opening, this life raft, if you will, then the insurance companies will go back to the hospitals and the providers and say, look, we're losing volume. We've got to lower our rate. And that's exactly what the intent of this is. It's calling into their question their value proposition. And if they don't want to change, then people at least can continue to use the lifeboat to keep us escaping over every single time, as long as they can find a cash provider that's less expensive.
Charles.
Thanks. I was going to show a cash appointments app that Freedom Hub promotes, but then I saw Dean Jargo in our participants list. And Dean, if you want to unmute yourself, do you want to ask a question about the role of bundling to facilitate transparency and price sensitive shopping by the patients and health payers?
Happy to. Thanks, Josh, for your presentation. Josh and I have ever actually talked separately, so he's heard my barrage of questions already. And Charles, if you want to show Wow or whoever you were going to show, feel free. I'm fine. I like a robust market. I'm a free market guy. I want lots of people out doing what we're talking about doing here. So if you want to screen share and show it, feel free.
Afterwards, I will, but why don't you kind of set the stage? Because I think those of us in the market, like you, me, and others, for me personally, I appreciate Trump's efforts to get 5% of the hospitals to comply. I think has been helpful to, like Josh said, expose the cynical way they disclose prices has been eye-opening. So folks know that we're not just shouting in the wind about corruption in the hospitals. It's kind of a hospital insurance cartel, throwing pharma there. But, I don't think it can be emphasized enough how important the entrepreneurs are, because of the cartel strangleholds on their public politicians and the media. It's going to take the handful, including you, Sydney, and Jawad, to disgorge those bundles out of the hospitals and the independent clinics, and to get the big group payers to use them, which is like, banging your head against the wall sometimes, whether it's you or what I'm doing with sharing, combining with another Trump expansion, ICRIS, through which we can bring sharing to larger and larger employers. So, if you want to comment on the significance of what you're doing, I think that's important in the context of Reformers Academy. Reformers need to know about what you're doing. What do you think about that?
Well, and I agree with all of that, of course. And just to put a fine point on what the Patients' Right to Save hopes to accomplish, we hear all the time from either business owners or individuals this issue of, and it's a fallacy, we can all agree, but people really do have a hard time thinking through this idea of, well, I need an MRI and I see it's over here available for cash for $400, and on my insurance network it's going to cost me $2,500, but if I spend $400, I won't get deductible credit, and if I spend $2,500, I will get deductible credit. And you would be amazed at how many people choose to spend $2,500 of their own dollars so they can get quote unquote deductible credit. And it's a psychological riddle that I can't really understand or unpack wholly, but it's a real hang up for people. And it's like, man, if we could take that hang up off the table, I think it really would unleash a whole new population of people who would be very happy to, spend $400 for an MRI as opposed to $2,500 shopping within their, large BUCA insurance network. So I think it's a real issue.
Yeah, I would just say two things. One on bundles and one on the process to change behavior. I think this is a challenge going forward on price transparency, because while there are good players and actors like Dean and others looking at bundling services, and that is so important, I have no doubt that the incumbent players will try to make that as hard as possible to make, so you can't do an apples to apples bundle. And that's why I think the cash disclosure and trying to figure out, and I think policymakers have missed this boat for years, and putting myself included, making sure that there's no barriers preventing providers from disclosing cash rates is important. I mean, we hear from providers, we think contractually we're not allowed to do that, or we believe we're going to lose Medicare or Medicaid because if we disclose a cash rate. So that's step one. Step two is, once you disclose it, can you do it apples to apples? And ideally, bundles, I think, make sense to me. Can you come up with standardized? And Dean is far more expert in this than I am, but I think that's the challenge. And I think policymakers need to at least stay aware of those challenges and figuring out what guardrails, and I mean, just basic, like stop the bad behavior guardrails that might be needed going forward, not being overly prescriptive or prescribing what the bundles necessarily even have to look like, but just saying, like, hospital, we have to be able to tell when certain things are going to be included in a service. Like you can't disclose data makes so little sense that we can actually understand that for an MRI or for a surgery, what's going to be included if we come see your service. So that's the first one. The second one, I think, is probably the entrepreneurial challenge on price transparency, which is, and I'm sure you all know this from yourself or talking to family members, like my wife is a perfect example. You have to make it as easy as possible with the least amount of resistance. And so the tools have to be, she's in her doctor's office, pull out her phone, easy, 1 or 2 clicks. And more, that's what we're hoping with Patients' Right to Save, is that it empowers companies to say, right now, many of these marketplaces, you have to go back home, or maybe you could hop on your phone and maybe try to find a cash-based provider if you even know that they exist, and then maybe make an appointment. It's got to be all-inclusive where you're in your doctor's office, you hop on, you select it with your doctor, it makes the appointment for you. It files, in the case of our reform, it files the paperwork for you with the insurance company on the back end, so that it actually feels easier for the patient to make those sorts of transactions. I think that's how you're going to get, from 20-30% engagement for patients up to 50-60% of them willing to do it. That's the challenge. And I'm optimistic. There are good folks in this space, but I think it's just going to take a little time for us to get there.
Yeah, I agree with all that.
I might add to that, in our several years of upgrading folks, our word, from insurance to sharing, because sharing doesn't have networks that exclude the best doctors you'd want. We found that having a concierge shopping assistant is the key. So after I educate someone on that upgrade, I tell them the only thing you have to remember is the 800 number, our concierge, if you get sick and need help, because we're going to hold your hand from the first dollar. And we'll use tools like Healthcare Blue Book to find well-priced providers, and we'll pay the provider directly, relieving you of the hassle of receiving bills and requesting money to pay the bill. So that comment you made, Josh, is definitely relevant in the commercial space, how to make it very easy for the patient, because we make cash patients and then they're intimidated. So we have to hold their hand from the first dollar onwards. And sharing only kicks in at $1,000 or even higher, 2,500 or 5,000. And a lot of these costs, like MRIs, X-rays, tests, labs, minor procedures, are below the deductible, or in our parlance, the IUA. So the sharing company's not going to help you. The insurance company's not going to help you for a lot of your expenses. So you got to have help for the hundreds of dollars expenses, not just the thousands of dollars expenses. And I'll go into another question here. Well, I've got the floor, Jim, unless someone else wants to throw in a question. Dr. Montalvo, I'd love to have you raise your hand, talk about Health Reformers Academy for improving healthcare, because we do care about that, because the chronic disease epidemic, as Robert F. Kennedy so eloquently says in his speeches, is the epidemic of the day. It's affecting half the population, up from 10% in the 1980s. And pharma has stood somewhat impotent to stem the real epidemic, chronic disease. So I think people have got to upgrade their idea of what healthcare is. Before, John, you talk about that. Talk about, Josh, if you don't mind, the role of loosening restrictions on health savings accounts to further empower the patient to take control and have some tax advantages in shopping around. How important is that part of the Health Reformers Academy, self-insurance through HSAs?
Yeah, it's certainly something that we talk about with the fellows, and I think there's lots of promise there. I think there's 2 political challenges to it. One, it holds a massive fiscal note when the Congressional Budget Office looks at it with any expansion for HSAs. So that's one kind of piece of it. The other is, depending on what proposal's on the table, whether it's how much money you can put into the HSA or who can have HSAs, there's questions about how they get utilized. And, folks on the left often say, well, it's really just a middle class way to hide money going forward. So there's some political bipartisan challenges to getting buy-in going forward on the proposal. But I certainly think that they are part of the solution to help people feel empowered. I think with some of the conversation we've been having, there's just a trust issue in healthcare, in terms of third parties being involved. Generally speaking, public polling, and the folks that are providers on the call can speak to this, like most people trust their providers. But outside of that, they don't trust many other people. And so if you're offering them a service or technology or others to try to, that is truly in their best interest, we find just lots of skepticism that they're somehow the shoe's going to drop and they're going to get screwed on healthcare. And so I think figuring out the messenger, and Charles, I think you were mentioning that in your services, somebody holding your hand through the whole process. I think we have to think more about that. Like, what is the high touch ways to help people gain trust that what you're providing them is actually in their best interest? And that probably needs to look different for different people, but that's a real challenge.
John, thanks. John, you there? Dr. John?
Yep, I'm here. We can get, okay. It's a little slow at the internet service here. Can you hear me?
Yep.
This is all quite interesting, and thank you, Charles, for kind of calling me out here. This is all great concerning this healthcare system, but the gentleman who just gave the presentation, I'm sorry, Josh, I think what we're failing to realize is we don't have a healthcare system. We have a disease care system. And the only way to lower pricing, in my estimation, is to have fair competition across all types of healing modalities. I spent 2 weeks in Texas recently teaching on homeopathy. At one point, homeopathy was a major healthcare provider in the United States and was outpacing what they call orthodox, or how Samuel Hahnemann talked about was, oh man, I just lost the thought process right there. Allopathic care. And homeopathy, based on a memo or a study that the World Health Organization put out back in the 90s, before it became the evil empire, or maybe it was back then, basically stated that if all countries incorporated homeopathy, there would be a 50% reduction in healthcare. 50%. So one of the issues that we have with healthcare, and actually we should have a wellness care, and Mark Aubrey, who sometimes attends here, him and I agree. We need to have a wellness care and go back to the quote unquote old days, where we're teaching people how to maintain their wellness and not rely on doctors. And understand this, Josh, I spent 13 years in academia. I have been training allopathic doctors, whether it be DOs, MDs, nurse practitioners, physical therapists, nurses. These people are not really taught how to heal. In fact, Dr. Bruce Lipton clearly said in a seminar, and he was training medical professionals, these people taught how to remember, not how to think. So we need a totally different wellness paradigm, and Mark has been working on it. I haven't been in contact with him for over a month, where we are really healing people and teaching people how to heal. The Latin word for doctor means teacher. How many MDs or medical doctors do you go to that actually teach you how to heal? No, all they do is listen to you for 9 minutes and write a script to take care of your symptoms, but not to get to the root of the cause. And what's strangely, now you have this certain sect of the medical profession. Now they want to call themselves, what's that new terminology that they call themselves? Functional medicine doctors. There we go. That's going back to the old days of naturopathy, where the naturopath was actually seeking the root cause of the disease, which goes back thousands of years to Hippocrates. So we need to look at that and stop looking at this flawed deeply flawed. If anything, the last 3 years taught us is that the medical profession is just following what they're told, because the majority of doctors are stuck in a system that if they don't follow the system, they lose their income. And we need to break away from that in order to truly provide wellness care and not this health care.
Josh?
Yeah, I mean, I don't necessarily disagree. I think there's a couple things that I would just comment on that. For somebody who's been in the policy space for a while, I think there's very little understanding of the impact of lifestyle choices on healthcare spending. That's part of what we're trying to do as training future policy folks. It's just to have a broader view of what is driving healthcare costs. I mean, and you all know this, but looking at chronic conditions, that's driving a lot of the healthcare spending. So, to the proposals that we're putting on the table around price transparency are the low-hanging fruit. They're not going to solve all the problems by any stretch of the imagination. In fact, it's more of an efficiency play than anything. And I think it's important to do two things. One is educate policymakers of what should be out of their control. I think most folks on this call would probably be very uncomfortable if the government just started mandating all sorts of things on lifestyle choices and behavior. But a conversation needs to happen, and we probably need to stop doing the bad things, the things that are causing real health problems going forward for unhealthy lifestyles. So I don't have the good answer on it. I think that the longer I've been in the policy space, the more I've realized that entrepreneurs and people who are building a parallel system or other options is just as important. And so a lot of the policy work we've done over the years for the organizations I've worked for is just making sure that there's no barriers to allow those alternative parallel systems to emerge, whether it's sharing plans, whether it's farm bureau plans, which have popped up in a number of states, which are not insurance type plans that allow for some of this longer term thinking and investing in wellness, direct primary care doctors. On the policy space, it's remove the barriers, don't mandate down, has been the general approach that we've taken. And I don't disagree in sharing your skepticism that the status quo players are going to radically change their mode of operation in the next few years, whether it's the hospitals, the insurers, whether it's the federal agencies regulating them. And so that's the approach that we've taken on the policy side. And it's up to you all to, I think, be out there on the ground actually helping folks live that out day to day.
John, let me suggest a couple of policy changes to facilitate your comments, and maybe Dr. Singleton can unmute and comment on what I'm about to say. So I'm also the lobbyist for the world's oldest health freedom organization, National Health Federation. And I have a few campaigns on that upgrade of the actual care. One is the FDA has several guidance documents that affirmatively are smothering the superior health markets that John mentioned. They want pre-approval for homeopathy, for nutritional supplements, and for natural compounding. The latter, which is something I want to learn more about, but compounding has a lot of potential for personalizing what is prescribed. A lot of these pills have a lot of additives and allergens in them that you don't want. That's why they have so many side effects. And that is part of the supply, there's supply and demand in healthcare. The FDA is rotten on so many levels. Also, state licensing scares doctors and keeps them in their box. Oklahoma, you mentioned Tennessee. I have a senator in Oklahoma who has a bill from the Goldwater Institute that would exempt any occupation from licensing if you are following the criteria of a registered certifying organization. That would change the current lowest common denominator dynamic, which stems from licensing, to a race to the top dynamic, where new organizations would form constantly to market their brand to the consumer, like No GMO Project, or Montalvo's Superior Integrated Network, or Jim Grapek's Pavilion Doctors. And the only role for the government in that would be prosecution of fraud, which is a basic AG function in each state. It simplifies the matter. And then probably repealing con to allow better hospitals to form. Hospitals need to be punished for what they did during COVID. And we need better hospitals based on hospitality. Rapek's an expert on that. Anyone that's had a new baby, knows how tyrannical hospitals are. And, we want to have patients first hospitals. But I think those three changes would directly respond to what Montalvo and a lot of folks want to see, an upgrade in actual healthcare delivered. I haven't even mentioned the educational schools. Marilyn Singleton, do you want to unmute and comment on that? And maybe Josh can respond to that in your comment too.
Well, just going back to Dr. Montalvo talking about these alternative, quote unquote, forms of medicine, one of the key things that I posted, the actual numbers in the chat, are insurance not paying for it. And it's the same as insurance not paying for some of these various lifestyle change modalities that patients might get involved in. They're paying these premiums, and then suddenly, as the chat said, one insurer denied 49% of claims in 2021. But what's amazing, and it goes back to what Josh said about people paying $2,500 for an MRI just to get the deductible. People only appealed one time in 500 cases. And if people actually appealed, you'd be amazed at the positive result. My husband, engineer, knows nothing about medicine, got a denial from Kaiser of treatment of his elbow, saying it was pre-existing problem. Well, he went right to Kaiser's website where they had tennis elbow on there and described it. And the way they described it was exactly my husband's symptoms. It didn't say it was pre-existing or anything. Instantly, it got paid for. And I mean, he just did a cut and paste. It says, here's my appeal, and the link to the website. And patients have become intimidated and they don't appeal. And the insurers know this, so they deny. So they're denying other means of treatment that don't involve drugs. I just did on my podcast a talk on addiction, and the addiction physician was talking about non-medical medication interventions that actually improved the recovery for many patients, but some of them don't get paid for by insurance. So we flip always back to drugs, and more drugs, because they tend to always get paid for. And so that's my tirade about not even using insurance for all the money you'd save. And as you know, in AAPS, we really advocate for cash practices, DPC, and direct care, even in non-primary care, endocrinologists, neurologists, people where they see patients chronically. And the patients ultimately save money, not to mention their mental health improves because they're not fighting the insurer every step of the way. Thank you.
All right, thank you. John, you want to chime back in?
Yes, sir. One thing that Marilyn said there, she's correct about using insurance. The $2,500 for an MRI, I don't know if you guys recall, but back in September, I broke my back. Finally got back into town, had an MRI, and the cash price was $350. Normally, the insured price is $1,500 to $1,700. And something that just came to my mind was my homeopath, my master homeopath that I trained under. He stated something about the chiropractic profession. He said when insurance got involved with with the chiropractic profession, it ruined the profession, because now we're chasing dollars from the insurance company instead of providing the proper care to the patient and allow them to pay cash for the healing method that they were going for. And in fact, if you trace this back when the insurance companies started to come about, that's when we start to see the escalation of what we call healthcare in terms of pricing go up. So because of course, an insurance company is going to insure you, but they're out to make sure they get a profit because it's a business. It's a business. So they're going to charge you more money in the form of so they can gain profit, and they will deny as many claims as possible, even though those people that are denying the claims, they're not even doctors. They don't even understand the physiology of a human being or how somebody comes down with a disease. So it's up to them to go ahead and deny as many claims as they can in order to make more profit for the company. They're not really looking out for the insurer. They're looking out for the bottom line, just as in the medical profession now, where we have these computer systems in hospitals, and instead of the system pushing out what's best for the patient, they're pushing out what's more profitable for the hospital.
Josh,
Yes.
you want to kick in there? I think we've had
No,
several
I mean, I
soliloquies.
people are no, it's they're following the money, and I understand that, and it is unfortunate, and I think it's the irony of many providers saying I never follow the money, and then you look at the behavior and you're like, well, that's not how the practice is, and whether they're being forced to do it in a hospital setting or not. Again, I would just say from the policy side, this is why I want to underline the reason why we're pursuing alternative paths for folks to emerge is for this exact reason. And we can play whack-a-mole for decades, and some of us have been trying to play whack-a-mole and saying, well, stop doing this and stop doing this and stop doing this. And they just find creative ways to get around it and make money a different way. So I think it's time for you all, I'm sure, are saying this every day to people that you're interacting with. We have to do it differently. And from a policy perspective, our role is just to say, how do we allow that to happen? So.
Yeah, and how can we work? How can we and our people work with you? Yep. Yeah. Charles, I see you're back.
I'm back.
Ford.
I want to share just a brief example of our medical system at work, which I think plays in the conversation we're having today. I woke up with a earache last Thursday night, stayed up all night with it, tried to make an appointment to go see an ENT. You know, your ear aches, you would think you would go to an ENT. Don't use reason in our system because that doesn't apply. There's one ENT in town, a city of 40,000 people. That ENT works 4.5 days a week and does everything in the world but basic ENT. He's got all this other side business he's in on and makes all this tons of money out of it. I had to wait 3 months to go see. 3 months with an earache. So then I was forced to go to a primary care physician. I never did see a physician. I saw a bunch of nurses, and they did a bunch of tests that had nothing to do other than with wellness, which I was not interested in the least. We can get started on that diatribe. At one point, they took my blood pressure. I asked what it was. She said, I'm not going to tell you. And at that point, I looked her straight in the eye and I said, let me explain something to you. It's my blood pressure, my body. You will tell me, or I'll just walk out right now. Now, that's what our system has come to. And people think you can reform that good. If you want reform, let's do it this way. Let's start with this. Let's get the frickin' doctors out of about half of the process. For instance, I had an earache. That's an infection. Why can't I just go to a pharmacy and say, hey, pharmacist, I've got an earache. What's the best antibiotic to use for that? And he gives me the antibiotic and he says, you know, if it's not better in a couple of days, you don't see improvement, go see an ENT. And why can I not have direct access to an ENT when I have an earache? This system is so incredibly stupid that I can't even begin to get my arms around it. And you wonder why the expenses are out of control? Well, you could start with the fact we have McCarran-Ferguson from a legal standpoint. Get rid of McCarran-Ferguson and do away with the antitrust exemptions, and you might see some improvements. But my point is, I did not hear anybody today talk about just the fact that the doctors are and the nurses and the way that they have their exclusive control over all processes damages the system, prevents the operation of a free market. I should have the right, R-I-G-H-T, to go to a pharmacist, and a pharmacist should have the right to say, you know what, Mr. Ford, try this. If that doesn't work, go see a doctor. And that would solve probably 40% of the foot traffic. And then we get into the other problem, which is very simple. There's no supply. And why is there no supply? I've said this before, because the AMA and the government controls the supply. And as long as you continue to have that, you guys can talk about changing this and changing that and creating this, cash that. As long as the supply is controlled by a monopoly, you're not ever going to have a successful market. It's impossible. The government is a monopoly. Do monopolies ever work? No, not now, not yesterday, not tomorrow, not ever. Crash the monopoly, start with McCarr and Ferguson.
You want to?
Well,
comment?
I won't tackle that one just because of federal issue in terms of the politics on that one. You can't get them to do much of anything these days. But on Charles' other point, the state of Idaho and Montana have both passed laws allowing pharmacists to directly prescribe to patients. I think that's going to gain some traction, especially in more remote states. We are, some of the think tank groups that I work with that are much more active on policy reform at the state level are very much in active conversations with Cato and others about alternative pathways to become a provider. For the reasons stated, I mean, the current system is just silliness. So is there an apprenticeship type model in which you can get more people to be qualified providers? And I know people feel differently about this one. So it's just a question of what are those pathways? How do we get there? What provides to our earlier conversation about outcomes, what allows you to feel comfortable that you're going to get as good, if not better outcomes. But the reality is, and I say this probably daily to a policymaker, the alternative not here is the perfect example versus where we are now. It's they don't see anybody versus option. So when it comes to access, whether it's an alternative method that we've been talking about, or whether it's just seeing pharmacist or a doctor or an ENT or whatever, in many parts of this country, as you all know, there just is nobody. And so we have to think outside the box, and we have to go over the objections of the very powerful doctors' lobbies in some of these states, hospital lobbies, and the insurer lobbies. We need to say we got to put patients first and give them options. Don't force them to use the options, but allow them to have options. So that I think it's spot on that there's attention needs to be paid on those, and I'm hoping that it will continue to spread at least at the state level.
Okay, last question. Just got a minute, Linda, something quick?
I would like to tell you, I am Greek and I had the chance to study the 5 volumes from Hippocrates about medicine and the methods used by other 450 ancient Greek doctors. Compared to what they say or what they did, and the actual US medical system is day and night. I mean, the medical system maintains and causes disease instead of preventing and curing. And I fully agree with Dr. John. So if we don't change the mentality totally and open a court against this medical system in the US and the companies, I don't see any change. I'm writing 2 books right now, how to prevent disease. That will be a small change, maybe. I'm not going to use my name because my life will be in danger, of course. But what to tell you? So depressing, so disappointed. Anyway.
Okay. Thank you, Linda. Josh, you want to do a 30-second wrap up and maybe tell people how they can reach you, your website, and so on?
Sure, yeah, I put in the chat, HealthReformers.Academy. If you would like to learn more of that, I put a link to the paper on the price transparency reform. You can get to me either through either of those websites, or you can find me on LinkedIn. Happy to stay in touch. And please do think and reach out if you either have people who you think would be interested to go a little bit deeper on the policy side, whether it's to become a political appointee or work in a policy opportunity, or if in your day-to-day practice, if you come across regulatory barriers that you said, you know what, we would do something different here if this wasn't in place, please feel free to reach out. We're always looking for opportunities to try to remove barriers. So please feel free to do so.